everyone, and welcome to today's PHO Rounds presentation on IPAC and Medi-spas Head to Toe, What You Need to Know. My name is Ann Augustine, and I am the team lead of the Infection Prevention and Control Lapse and System Support Team in Infection Prevention and Control at Public Health Ontario, and I have the pleasure of moderating today's session. Next slide, please. I would like to start today's session with a land acknowledgement. This land acknowledgement was developed by the ILSS team at PHO, a team whose members are scattered across the province. So I thought it was a fitting land acknowledgement as those who are providing and attending the webinar today are also scattered across the province. So we acknowledge and respect the lands, sky, and waters of Ontario, including their contribution and sharing to support all life within. We acknowledge and respect the treaty, unceded, and traditional territories of all First Nations across these lands and waters. We acknowledge and respect the traditional territories and communities of the Métis Nation of Ontario, and we acknowledge and respect the Inuit connection and contribution across these lands and waters. May we respect and honor the connections, relationships, and life journeys of Indigenous people and their indigeneity to the lands, sky, and waters across all Ontario since time immemorial and to this very day. May their wisdom always guide our own paths forward with open hands, open hearts, and open minds for the mutual success and benefit of all in Ontario. Next slide, please. So our disclaimer that this presentation is created by its authors or external organizations. PHO is not the owner of the content, and any application or use of this information is the responsibility of the user. PHO assumes no liability. Next slide, please. These are our learning objectives for today. And just to let you know that these are overarching learning objectives for the entire session. Also, a little bit of housekeeping items that I need to discuss. To ensure an engaging and optimal experience for all, the Zoom chat and audio video features have been disabled for this session. Please feel free to submit any content-related questions in the Q&A function at the bottom of your window, and they will be addressed during the discussion period. For technical issues, please email capacitybuilding at oahpp.ca. Next slide, please. Now I would like to introduce our speakers for today. It's my pleasure to introduce the speakers of Lara Sagan, Dr. Maureen Savadino, and Zorica Winovich for today's presentation. As well, we have panelists of IPAC specialists joining us today, David Riding, Ray Gullickson, and Catherine Kerr, who will join us during the Q&A portion of the session. Lara has been a policy and program advisor with the Ministry of Health since 2016. Her portfolio has focused on infectious diseases and surveillance, and has previously included opioid overdose surveillance, respiratory outbreak surveillance, regulatory changes related to the reporting of diseases, and COVID-19 guidance for congregate living settings. She joined the IPAC team in 2023 and is currently focused on IPAC lapses. Laura has recently achieved her certification in infection control and looks forward to continued learning about the field of IPAC and improving public health. Dr. Maureen Savadino is a physician certified in family and occupational medicine. Dr. Savadino also holds a diploma in occupational health and safety, and she maintains her certification in infection control through the Certification Board of Infection Control and Epidemiology. She provides IPAC physician support to Public Health Ontario and works as an occupational health in acute care. Zorica Winovich is an infection prevention and control specialist at York Region Public Health with an extensive experience in infectious diseases and infection prevention and control across diverse settings. She has led and supported numerous IPAC investigations spanning healthcare facilities, personal service settings, and other community environments. Saritza is deeply committed to excellence in public health and IPAC. Next slide, please. So this slide is just to let you know that none of our speakers have any conflicts of interest to disclose. Now, I pass it over to you, Laura.
Thank you so much, Anne, for that lovely introduction, and hello to everyone. I will be describing the provincial legislation as it relates to personal service settings and the role of regulatory colleges, and finally a description of what controlled acts are and how they are delegated. I'll start off by recognizing that the Ministry of Health doesn't actually have a definition for the term Medi-spa in the legislation, so you'll notice that in my presentation I use the terminology of personal service settings, or PSS. Next slide shows our slide progression. So I'll first provide a bit of an overview of the legislation as it relates to PSS, how the ministry and public health units, or PHUs, typically engage with the regulatory colleges, a little bit about the roles and responsibilities, and lastly, some considerations for regulated health professionals, or RHPs, that are working in PSS. On the next slide, I know it looks a little bit overwhelming, and I'm so sorry for that, but we felt like because of the diverse audience that might be here at the rounds, it was important to kind of set the stage for what the legislation actually is as it relates to IPAC and public health. So as many of you on the call already are probably familiar with, there are 29 public health units across Ontario. Each of these health units has their own board of health and their own medical officer of health. The main legislation that guides public health's work is the Health Protection and Promotion Act. So it outlines the role of the public health unit and the medical officer of health's authority and powers. There are two main types of orders that can be made under the HPPA by medical officers of health or public health inspectors. And this includes a health hazard order or a communicable disease order. So these are important during IPAC labs investigations. So just very briefly, I'll try to describe the difference in a very simplified way so nobody falls asleep. A health hazard order is made when the public health inspector or the medical officer of health determine that something inside the premises or the overall condition of the premises has or likely has an adverse effect on the health of somebody. So this type of order might require the premises or the operator to make certain corrections that they would need to follow. So this could include cleaning or disinfecting tools or equipment, or completely removing something from the setting. So for example, a sterilizer that's not functioning properly, that's not cleaning instruments properly. It might also require vacating the premises completely or just closing it down. The communicable disease order, on the other hand, is issued when the medical officer of health believes that a communicable disease exists, or that it might exist, or that there's an immediate risk of an outbreak of that disease in the public health unit. And this order is a little bit different because it can be applied to like a group of people and not just one person or one operator. The person who's receiving the order might need to start doing or stop doing a certain action that's specified in the order. So one interesting example of this is during the height of the COVID pandemic, when certain health units issued Section 22 orders or communicable disease orders to workplaces that had a certain number of COVID positive cases, and it required them to shut down their workplaces to prevent an outbreak from occurring in the community and in the workplace. And although we don't have a definition for Medi-spas, the HPPA does define a PSS as a premise in which personal services are offered where there's a risk of exposure to blood or body fluids, and includes premises where aesthetic services are offered. Next, under the HPPA, we have the PSS regulation. So this regulation outlines all the various requirements that a PSS would have to follow to make sure that they're minimizing the risk of infection transmission in their setting. The regulation allows the PHO to issue tickets and fines when they find any issues that are essentially in contravention of the regulation. So in addition to the 2 orders mentioned under the HPPA, a health unit might also be able to correct issues quickly through tickets and fines under this regulation. And over the years, we have received quite a bit of feedback from health units, just outlining all the different gaps that exist under the regulation. So this is kind of constantly something that the ministry is thinking about and discussing internally. The Ontario Public Health Standards are published under the HPPA, and they essentially set out the minimum expectations for public health programs and the services that should be provided by the health units. When it comes to IPAC, the work would fall under the standard of infectious and communicable disease prevention and control, which aims to decrease disease transmission in the community. And finally, our protocols. So currently there are 3 IPAC protocols that health units have to follow. One describes the IPAC inspections that occur on an annual basis. So this is for settings, PSS settings, as well as childcare settings. Another IPAC protocol describes how health units receive and respond to IPAC complaints in any type of setting. So this could be a doctor's office, any type of setting you can think of. And one describes how IPAC lapses that are substantiated, as well as annual inspections are disclosed to the public. So this includes kind of like the health unit's website, where they list all of the IPAC investigations, as well as the annual inspections. And on the next slide, it shows how regulatory colleges are engaged by both the ministry and the public health units. So at the provincial level, we do meet with all 26 regulatory colleges on a quarterly basis, and we use this meeting to discuss any IPAC issues or new resources that the colleges are creating. We might also meet with them on an ad hoc basis to discuss any emerging issues that we might be seeing. We've also sent out some formal correspondence to the colleges in the past related to emerging issues that we've been noticing. And from time to time, we've engaged with them to conduct informal surveys or polls, asking them about if certain issues are being encountered among their members. When it comes to how health units engage with the colleges, we recommend that they do contact them whenever there's a concern about the IPAC practices of an RHP, a regulated health professional or an RHP, whenever there's concerns about their professional practice, their IPAC practices. And we do encourage, ideally, we encourage a collaborative approach when the health unit is going out to do inspections, understanding that this might not always be feasible. And lastly, we do ask the health units to contact the appropriate regulatory college if they have any questions around the scope of practice of an RHP. So if you're not from a health unit and you're on the call and you're wondering why this is relevant, it's because in the PSS regulation, there is an exemption where the regulation doesn't apply to a setting where the personal services are primarily provided by an RHP who is engaged in the practice of their profession. So an example of what this might look like is that we're asking health units not to use the PSS regulation, not to apply it to a setting where an RHP, such as a dermatologist, is providing skincare services. So aesthetic skincare services, for example, whatever those might be. However, it's rarely as black and white as this, as we've heard, and there's often lots of complexities and nuances to this exemption. So in this case, if the PHU is kind of thinking about what may or may not fall under the scope of practice for that RHP, we have in the past recommended that they contact the college to seek advice on that. And on the next slide, we have the role of the regulatory colleges. So their main role is to regulate their members, to make sure their members are practicing under the standards of practice that they've set out for their profession. They've also they investigate formal complaints that are made to the college, including IPAC related complaints. And most regulatory colleges in Ontario have standards of practice for their members that specifically focus on IPAC. So a good example of this would be the IPAC standards of practice that are published by the Royal College of Dental Surgeons that regulates the practice of dentistry. And as part of our quarterly meeting with the colleges, we do discuss the development of their standards and resources for their members. On the next slide, we talk about the legal requirements for the health units. So these are the requirements that health units must follow on the left column, and the right column shows the practices that health units are not legally required to follow, but often do because it helps inform whether a health hazard exists. So on the left, you'll see that the requirements would involve that health units have to inspect PSS every year. They have to have a formal way of receiving IPAC complaints and responding to them. They must contact the appropriate regulatory college if they're concerned about the practices of an RHP, and they must take action under the HPPA if a health hazard exists or under the PSS regulation if it applies to that setting. And on the right side, it shows, again, not legally required, but often chosen to complete because it supports the identification of a health hazard. So this would include activities such as verifying the license of an RHP and making sure that they are in good standing with their college, that there are no restrictions to their practice, verifying proof of ownership of the PSS, and also understanding when a situation that's encountered in a PSS might be in contravention of the Regulated Health Professions Act, which I'll speak to in a few slides, or the Controlled Acts regulation. And the next slide speaks to regulated health professionals in personal service settings. So regardless of the many types of names that Medi-spas might have, there are legal requirements for these settings, as well as the RHPs that work in them. So as we already touched on, these settings are all being visited by the health units to determine whether or not they will be subject to the requirements under the PSS regulation. In terms of RHP accountabilities, it's important to note that the RHPs are always going to be subject to the act of their profession and the regulations under that act. So health profession acts might include, for doctors, for example, it would include the Medicine Act. For nurses, it would include the Nursing Act. RHPs are always supposed to be adhering to the standards of practice that are set by their college. The RHP is also subject to the legislation and regulations of the setting where they're practicing. So for example, if a doctor is practicing in a hospital, they would be subject to the Medicine Act, the Regulated Health Professions Act, and all of the regulations underneath both of those acts, as well as the Public Hospitals Act. Another act might be the Fixing Long-Term Care Act if the RHP is working in a long-term care setting. There's also legislation related to specific procedures that sets out certain limitations for what they can and can't do. And there also might be employer-related policies and practices that they would have to follow. And finally, the activities that the RHP can perform would be dictated largely by a self-assessment of their own competencies for doing that practice. So I often joke around with my team that when I go for my dental cleanings, I keep trying to convince the dental hygienist to give me Botox, and she keeps saying, no, that's not under my scope. I can't do that. I'm not competent. So that's an example of you have to kind of self-assess your own competency regardless of whether you have permission to do that act. And my final slide here, and I'll spend a bit of time here, it speaks to the Regulated Health Professions Act and the Controlled Acts regulation. So the Regulated Health Professions Act, excuse me, or the RHPA, is meant to make sure that RHPs are providing professional, safe, and ethical services. It also establishes a model where RHPs are able to regulate themselves through their own health professions acts and standards. Health Professions Act and the regulations are meant to set the mandate for that profession and define their overall scope of practice, including the controlled acts that they are able to perform. And when it comes to controlled acts, there are 14 in total. They're all listed under the Controlled Acts regulation of the RHPA. And some of them are encountered in these Medi-spa settings by PHUs during their inspections. Controlled acts might involve things like communicating a diagnosis or prescribing drugs, for example. And controlled acts might be performed by an RHP, but they might also be delegated. So the RHP might have legal authority to perform those acts, but they might also delegate that authority to somebody else. So delegation is the formal process where the RHP grants or transfers their authority to another person. And the person who accepts the delegation can either be an RHP or not. But essentially, the RHP who delegates is ultimately accountable and responsible for making sure that the act is performed safely. And they must also make sure that the person who's accepting that delegation is competent enough to provide that service safely. The requirements and responsibilities when it comes to delegating, also, as we've seen, they vary across the different professions, across RHPs. But the RHPs would also have to follow not only those requirements, the controlled acts, but also the requirements under the RHPA. Essentially, for public health units, if the practices of an RHP are in question whatsoever, the PHU should contact the regulatory college. And that includes if the controlled act is not being performed safely. So essentially, a summary of this slide would be to say that health units should be inspecting PSS for the purposes of the HPPA and its regulations, but that PHEs are not required by law to determine if something is a controlled act or not, if delegation is in place or not, and that is for the regulatory college to determine. And the next slide, I believe, is just, it's just a placeholder for our general inbox at the ministry's IPAC team. And if you have any questions or concerns, we're always looking for feedback on what is happening on the ground because we're not there, we don't see the issues. And it helps inform our policy making as well and our discussions. And that concludes my presentation. I will hand it over now to Dr. Maureen Cividino at Public Health Ontario. Thank you.
Thank you very much, and good afternoon and happy IPAC week to all. Welcome to our adventure, Medi-spas, head to toe, what you need to know. Next slide, please. I'd like to thank my co-authors, Ray Gullickson and Dave Riding, IPAC specialists with our ILSNS team, and for all of their contributions to the content of this presentation. Next slide, please. So there are specific objectives for this portion of the talk, really wanting to describe a broad range of existing and emerging personal service settings and products provided by a variety of operators across multiple settings, and to identify that along with IPAC risks, there are also health and safety risks. And finally, recognizing need for an approach to the challenges in this very rapidly changing field. Next slide, please. So truly from head to toe, there are a dizzying number of products available and procedures performed by a variety of operators across multiple settings. I refer to it sometimes as the Wild West, as things change so quickly it's hard to keep up. These procedures are performed by regulated health professionals, including RNs, RPNs, nurse practitioners, physicians, including primary care or specialists such as dermatology, plastics, and OBGYN, dentists, as well as a large non-regulated group who may have certification as a medical esthetician, for example, or may self-identify as such, even if they're not certified. And there are a number of operators who have absolutely no formal health training at all and have really learned their instructions for use from the salesperson that sold them the piece of equipment. So this little figure on the right of the screen is going to be our guide to what body parts are involved in our head-to-toe examination. Next slide, please. So it was really quite challenging with the everywhere, anything everywhere all at once kind of thing with public health units bringing in samples of exosomes with a number of complaints coming through and questions. And so we tried to put it into a way that we would do it sort of anatomically, regionally in terms of the presentation. So literally going from head to toe. So we'll start with Halo Head Spas. Next slide, please. So halo hair spas are also referred to as waterfall head massages, waterfall hair spas, Japanese scalp massage, and they're advertised as a treatment for scalp dryness, oiliness, dandruff, and for promoting relaxation, stress reduction, and overall well-being. The design includes a water delivery tube that has several holes in it that allows for a cascading stream of water, or it could be an elongated water spout that forms a sheet of water. It typically empties into a basin that often drains into a non-plumbed reservoir. So the unit is typically a standalone unit, looks something like a doctor's exam bed, where you would have the client lying on the bed portion, and at the head portion, their head would be supported by over a sink, and then the treatments would be provided, and the water then would go down into the reservoir, which typically would be recirculating. So it's very challenging, if you can imagine then, in terms of how you would clean and disinfect this, and particularly how you would do that in between patients with the large amount of water that would be involved. Next slide, please. So in July of 2024, as part of a Legionella case investigation, a public health unit identified exposure to a Halo hair spa device within a PSS as a potential source. The Halo device used an unplumbed reservoir with recirculating water. There was no MIFU or manufacturer's instructions for use, and no cleaning or disinfection protocols. And although potable water may have been used to fill the reservoir, it was contaminated by introducing hair products, skin and hair debris, into the reservoir, which was then recirculated and not changed between clients. Water samples from the equipment determined significant source of microorganisms. Next slide, please. So in IPAC considerations, use of a Halo hair spa equipment may create conditions in which Legionella and other pathogens proliferate. They often can have a heater, which warms the water and makes it even more of that case. Clients and staff exposed to a flow of droplets of contaminated water near the mucous membranes of the face and respiratory tract may also be at risk. Often there is a face cloth that would be put over, there would be aromatherapy and essential oils, and these are all things that would expose the mucous membranes. There is a fact sheet which is linked on the bottom of this slide, and hair spa services are to be plumbed and directly connected to a potable water source, not to incorporate water recirculation holding tanks, not to incorporate water recirculation from the hair wash basin, even for the same client, and to have manufacturer's instructions for use and to follow them. Next slide, please. Moving on to collagen induction therapies, common practices in personal service settings and Medi-spa type settings, and often marketed as improving the appearance of wrinkles, scars, uneven skin tone, as well as treatment for hair loss, and occasionally devices are used to inject derma filler. Traditionally, in microneedling, a derma roller is a small roller with needles attached to create injuries as it's rolled over the skin, leaving small, evenly spaced punctures. It is intended to stimulate healing, resulting in collagen and elastin production. Serums or other products can be applied topically after the procedure, using the breaks in the skin as the portal of entry for the products. Microneedling can also be combined with radiofrequency technology, where the radiofrequency is emitted from the needles in order to heat up the tissue during the procedure. This is marketed as causing greater damage to the skin and resulting in more stimulation of collagen production. Microneedling can also be performed with a stamp-like tool, usually with shorter needles called microchanneling, and mesotherapy, which uses needles to deliver a series of injections into the middle layer of the skin and often would be injected with serums and other substances other than skin. Next slide, please. So microneedling typically draws some blood onto the surface of the skin, posing a risk of bloodborne pathogen infection with hepatitis B, C, or HIV. The needle portion of microneedling device is considered a critical item. The needle head should be pre-sterilized by the manufacturer and ideally single-use disposable. Some manufacturers will provide guidance, which is incorrect in that it says that you can reuse needle heads. So it's important to note that MIFUs are not always consistent with IPAC best practices. And at times the needle cartridges also do not arrive pre-sterilized as they should. The classification of the handpiece is dependent upon the engineering controls that should be in place to prevent blood and fluid infiltration into the device. And note that non-intact skin is prone to infections from unclean hands, the environment, or the client's skin. And you'll see this below on a couple of other slides as we go, because it does apply in many different situations. Next slide, please. Complications include erythema, pain, edema, and temporary skin irritation. While these complications are generally minor and temporary, there are some microneedling forms, particularly radiofrequency, that can pose a risk of burns and nerve damage if not performed properly. And you could tell in this picture it is radiofrequency by the electronics in the cartridge head. Next slide. Many products carry significant risks and are classified as drugs. Sometimes they're deceptively marketed, implying they've received regulatory approval when they haven't, or that they're so safe that they don't need it when they do. Platelet-rich plasma is commonly being used. You may be familiar with it with the trademark term vampire facial. And it's also used for other therapeutic reasons, such as osteoarthritis in terms of joint injections. We'll also talk about exosomes and stem cell derived products, and chemical peels is another sort of topical drug, sometimes using fairly strong chemicals such as trichloroacetic acid. Next slide, please. When drugs aren't manufactured in accordance with standards and best practice, they can become contaminated with pathogens, particularly when components of the drug are of human or animal origin. In addition to safety risks associated with potentially using drugs that have not been licensed for use in Canada, transmission of bloodborne viruses and other microbial pathogens can occur due to unsafe and improper aseptic technique. Next slide, please. So here's a perfect example of the vampire facial. And during the summer of 2018, the New Mexico Department of Health investigated an HIV infection in a woman with no known risk factors. She reported receiving PRP facial after microneedling in an unlicensed spa. 4 additional former spa clients, including the sexual partner of one, developed HIV. And all cases were deemed related through nucleotide testing. Public Health conducted an inspection and identified multiple IPAC lapses, including storing the centrifuge and unlabeled tubes of blood on a kitchen counter, tubes of blood and medical injectables stored in a kitchen refrigerator alongside food, and reuse of single-use disposable electric desiccator tips cleaned by alcohol immersion. Next slide, please. And moving on to exosomes, which were new to us about 18 months ago. But as I said, with public health inspections at various public health units, a number of these products have been brought in for us to review. So we have done quite the library search and are looking at what are they, what do they do, what's the value in aesthetics, and what are some of the complications that might occur. So essentially, they're tiny membrane-bound vesicles between 30 to 100 nanometers in diameter and secreted by all cell types. Initially thought to be carriers of cell waste, now evidence to suggest they're active in cell-to-cell communication, transporting complex cargo such as lipids, nucleic acids, genetic material. And the cargo is selectively uptaken by local and distant recipient cells and influences various biologic processes such as gene expression, cell-to-cell signaling, immune response, and tissue repair. Next slide, please. Here's a graphic illustrating a sample exosome on the left with its cargo in the center. Exosome sources are categorized as either conventional or non-conventional, conventional being either human or animal. And these can include cells in tissues such as adipose tissue, umbilical cord, placenta, bone marrow, as well as a number of body fluids, including blood, saliva, urine, milk, and amniotic fluids. Non-conventional sources, typically non-human, non-mammal, and include animal products like honey and snake venom, as well as plant products, including fruit, seeds, pollen, and some microbial exosomes. Next slide, please. They do show promise for several therapeutic applications for cancer and other diseases, as well as for cosmetic applications, but there are still many unknowns. Due to their natural origin and biocompatibility being explored as a potential vehicle for drug delivery and novel vaccination delivery mechanisms. This is possible because they can be engineered to deliver diverse therapeutic payloads directed to specific targets. They're found in all biological fluids, readily accessible for sampling and testing, and have a potential to aid in both diagnosis and prognosis for diseases. Relevant to today's talk is the cosmetic application found in topical creams, serums, and masks. And applications include skin rejuvenation, wound healing, hair growth, and reduced photoaging. At this time, though, it's important to note that there are no topical exosomes approved by Health Canada of any origin, and topical products containing human-derived exosomes are currently under review to determine if they are inherent drugs. It's also quite possible that operators, including regulated health professionals, are unaware that exosomes have not been approved for use in Canada, and challenging as they're so widely advertised online and easily accessible for purchase. Next slide, please. So it's delivered topically without disruption of the skin barrier through masks, serums, and just rubbed in. Or it can be done with disruption to the skin barrier by a number of the ways that we described earlier with microneedling, chemical peels, etc. And finally, percutaneously through intradermal, subcutaneous, and intravenous routes. Next slide, please. So the exosomes, there are a number of health and safety risks associated. They may promote an infection or play an anti-infective role. This slide is a good visual representation of what we've just been discussing. You can see, regardless of whether the microorganism is a virus, bacteria, fungus, or parasite, that exosomes are developed intracellularly, secreted, and then can transmit entire pathogens or pathogenic genes or pathogenic proteins to target cells, which then results in either direct infection, alteration of gene expression in the cell nucleus, or can have influence on the pathogen virulence factors. Next slide, please. A key challenge with exosomes is how they're sourced. From human sources, they're more likely to contain human pathogens, but from animal sources, there could be zoonoses, for example, Q fever, if proper controls are not in place. It's very important to have thorough screening of exosome donors. They should be screened for bloodborne viruses and bacterial pathogens. Manufacturing techniques are important for two reasons. One is their small size, which makes purification of exosomes particularly challenging, and breaches an aseptic technique. Currently, no agreed upon process on how best to purify them. Next slide, please. Since 2020, the FDA has issued several warning letters related to manufacture and distribution of exosomes. The results of 4 inspections across 3 facilities came up with 50 different infractions, poor quality control, asepsis, failure to screen. And in addition, there were failure to reject batches after the donor plate had microbial growth, and distribution of products after testing positive for gram cocci. Next slide, please. So this is just a list of under additional sterility failures and the variety of organisms that have been cultured. Next slide, please. In Nebraska in 2019, there was an outbreak of 5 E. coli sepsis cases, all occurring within hours of receiving IV exosome treatment. It was through quick thinking of Dr. Maureen Tierney, who led the Nebraska Healthcare Associated Infection Antibiotic Resistance Team, who shut them down. Exosomes were sourced from harvested human placenta. Product was unregulated, not approved by FDA, and not associated with any clinical trials. They relied on internal protocols for safe production, and within 2 days, the bacterial isolate from the contaminated product matched the clinical specimens. Next slide, please. There are other case reports, including development of papules and nodules. 8 individuals reported erythematous indurated papules at the site of exosome injections, with onset ranging from 2 weeks to 3 months post-treatment. A case report of a 50-year-old who 7 weeks after exosome treatment had nodules and was diagnosed then with a foreign body granuloma. And finally, a third case, a 36-year-old individual who had skin necrosis 3 days after exosome treatment. Next slide, please. So there is also risk at point of administration. On-site mixing can affect the integrity and stability and function, as well as the therapeutic effect. Dosing, as I said, can be really very tricky, and improper handling and storage. Next slide, please. Moving on to energy-based devices, which are very common in PSS and other settings. Some procedures aren't new, but the settings are. You're likely most familiar with lasers for hair removal, but their use has expanded to include skin resurfacing, endovenous lasers used to treat varicose veins, and lasers for vaginal rejuvenation. Other energy-based devices include radiofrequency energy applied to heat up specific areas in attempt to stimulate new cell production. Cryolipolysis, referred to as fat freezing, known by the trade name cool sculpting, uses extreme cold to freeze and kill fat cells. And intense pulse light treatments are a milder, non-ablative laser for treatment intended to treat various skin conditions, and sometimes referred to as non-laser light therapy. Next slide, please. So if you didn't know what laser stands for or where it comes from, it's from light amplification by the simulated emission of radiation. And there are hazard classifications, mechanisms of action, and from an IPAC perspective, Spaulding's classification. The hazard classification ranges from 1 to 4, and a PSS typically will be a class 3B or 4, meaning that they can cause eye and skin damage by both direct and reflected viewing. They also pose a risk of fire at class 4. From Spaulding's classification, traditionally, if you're looking at laser hair removal, that would be considered non-critical. However, if there is a laser used to treat a mucous membrane, such as a typical vaginal cavity, or enter a sterile space, such as the vascular system, classification under Spaulding changes and the level of reprocessing needs to be increased. Ablative lasers vaporize tissue, generating a plume of surgical smoke that's exposed to, if the skin is exposed to that, it's considered to be not intact. Non-ablative lasers heat the underlying tissue but leave the skin intact. And finally, there are both types of lasers can be either fractionated or non-fractionated. Non-fractionated lasers treat the entire surface area, while fractional lasers only treat small areas and are less likely then to promote infection. Next slide, please. So vaginal lasers have really become prominent for use in PSS and Medi-spas. It is important to note that there's only one approved use for vaginal rejuvenation, which is genitourinary syndrome of menopause in women. And these are actually being advertised on menus for premenopausal women where there is no indication for their use. The handpiece should be considered critical, as the mucous membrane inside the vagina may become compromised as a result of the procedure. Next slide, please. Ablative lasers create a plume of surgical smoke, which can be a potential vehicle for transmission of viruses to healthcare workers and operators. The surgical smoke produced in the treatment of HPV-related lesions can contain HPV DNA in the respirable range. Other viruses have also been implicated: varicella zoster, HIV, and hepatitis B. The smoke can contaminate the environment and can contaminate the PPE of the operator. Both infective and malignant cells have been found in the smoke plume, but the full extent of occupational risk is unproven at this time. Ablative lasers need controls to mitigate risk of plume, engineering controls to improve ventilation and plume evacuation systems. The laser itself poses a risk of disease contamination if it's not reprocessed properly. And eye protection, which is often reused by multiple patients, can be damaged by some disinfectants and functionally impaired. So important to check the quality and cleaning of the eye protection. Next slide, please. So health and safety risks: bleeding, edema, crusting of the skin are common. Systemic reactions rare, but possible, and include burns and eye damage. And you can see from this photo, which is a stock photo, that in fact this is not being done appropriately, and that there's no protection for either the operator or the client. Next slide, please. So appropriate that our little figure has turned around and that we're talking about alternative health therapies at this time. So yoni steaming these are devices that are often homemade and typically not used by regulated health professionals. It involves sitting over a pot of hot water or other steam device to allow herb-infused steam into the vagina. There are lots of health benefits claimed, but no science to support it. One example PHO was consulted on included a homemade device consisting of a toilet seat over a store-bought humidifier. If the equipment's not maintained properly, it carries risk of infection, but also risk of burning. And there was a reported case in the Journal of Obstetrics and Gynecology of a second-degree burn. Cambotherapy is folk medicine linked to indigenous peoples in the Amazon basin, involving the use of a hot stick or strike brand to create burns on the skin, and the toxin of a giant leaf frog is then applied to the burn. The body then undergoes a purge through vomiting and diarrhea. In addition to IPAC concerns, there are a number of very serious health risks, including inappropriate ADH, acute renal failure, autoimmune disorder, ruptured esophagus, severe psychosis, toxic hepatitis, and death. So definitely not recommended. Colonic irrigation, also referred to as hydrocolonics, is a procedure that flushes out the colon with water or other liquids. And we'll talk a little bit about that on the next slide, please. So it's a tube which is part of a colonic irrigation kit inserted into the patient's rectum, and warm water is introduced into the colon. An open system, the water is gravity fed, and the waste will flow down the drain into the base of the bed. And a closed system is connected directly into the water system and is under pressure. The waste is evacuated into a sewage system. So there are greater issues with the one under pressure because it can cause some significant health issues. Next slide, please. So another example showing you the closed system on the left, where you can see that it is directly plumbed. Next slide, please. So there are risks at point of administration as well. The tubing is difficult to clean and should ideally be single use. Between 1978 and 1980, there was a large outbreak of amoebiasis with 38 cases linked to colonic irrigation facility that was reusing irrigation kits. So they are now all to be single use. And there have been additional infections linked to translocation of bacteria from the patient's own gut into the blood or extraintestinal sites. Next slide, please. So some other safety risks then, bowel perforation is a documented risk with the closed system and can lead to septicemia and death. Additional complications are burns if the water temperature is not regulated or other liquids are used, such as hot coffee. Electrolyte imbalance is a risk due to the large volumes of water. In the gravity-fed system, they'll use up to 60 liters of water in terms of a flush out. So no surprise that you'd end up with hyponatremia. And also plumbing considerations to ensure backflow does not occur and potentially contaminate the municipal water supply. Next slide, please. So we're getting through to the end of our whirlwind tour, now wrapping up with foot care. So nail cutting then involves trimming of nails, followed by smoothing and roughing of rough edges or shaping the nail, treatment for ingrown toenails, callus removal, and cuticle care. Next slide, please. This is just showing the difference between what would be considered a pedicure and a foot care. So it matters in terms of the intent of the procedure, the population that's being served, who the service provider is, the invasiveness of the procedure, and the level of reprocessing required. So important to note that under foot care, it is more likely to be invasive. It's more likely to be by medical health providers, and sterilization is required. Next slide, please. So this is just an example of an ingrown toenail and showing you some of the equipment that's used. And especially if there's any kind of removal of the nail, often there will be blood. So when we're looking at foot care lapses, it's really what we're very interested in, any of the more invasive procedures. Next slide, please. So there are IPAC risks, and these can be viral, bacterial, mycobacterial, and fungal. There have been a number of fungal infections that have happened without having proper reprocessing of equipment. And again, these other sources of infections around the contaminated environment and the client's own bacteria and unclean hands. Next slide, please. Other hazards include microbial dust, which could aerosolize along with fungus or body fluid particles, chemical hazards, polishes, strengtheners, removers, disinfectants, etc., and sharps injuries. So cradle blades are the ones that is another tool that's used, particularly for thick skin, is banned for use in a number of the United States, is available in Canada, is used, should be single-use disposable, but we have seen cases where in fact it has been reused and not reprocessed properly, and those are the things that make us more concerned for our foot care lapses. So finally, we come to the summary. So there is an ever-changing and expanding scope of practice among various regulated and non-regulated health professionals and operators in these settings, at times working without proper delegation or clear delegation of authority. From head to toe, multiple products and practices that can result in serious harm to clients, occasionally operators, including injuries and infections. Exosomes offer exciting promise in disease research as a vehicle for drug delivery and cosmetic applications. However, there have been serious reported adverse outcomes. And at this time, Public Health Ontario is unaware of any exosomes approved by Health Canada, although they are widely in use. So I will stop there and turn it over to Anne for the Q&A portion. Thank you very much.
So thank you for some two great presentations, Laura and Maureen. They were incredibly insightful. And now we'll move on to the first of our two question and answer sessions to answer questions from our audience live. So if I could ask Dave, Ray, and Catherine to join us, and we'll dive into the questions. If you could advance to the next. Where are we?
I can get us started, Anne.
Okay.
So we have a question for Laura. It's, do medical aesthetics clinics fall under the definition of a personal service setting?
Yeah, so this would really depend on the services being provided, like the inventory of services being provided in that setting, and who is providing them. So from the ministry's perspective and for the application of the PSS regulation, health units should conduct an assessment of each of the premises to determine if it meets the definition of a PSS. And if it does, then it would therefore be subject to the requirements of the PSS regulation. So if the services are primarily being provided by regulated health professionals who are engaging in the practice of their profession, then it would be likely that the Medi-spa would be exempt from the PSS regulation.
Thank you. I believe our next question is also kind of best answered by you, Laura. It's, who enforces the Regulated Health Professions Act when a personal service setting operator is found to be performing a controlled act but does not belong to any college and the PHU does not identify a health hazard?
So the RHPA, I believe it's jointly enforced by the Ministry of Health, by our colleagues in the Ministry of Health, as well as the regulatory colleges. And the question kind of touches on what we've been hearing is a largely a gray area in the legislation. So it's a bit convoluted and complex, but just bear with me. So if it is a non-RHP performing a controlled act for the purposes of providing healthcare services without any proper delegation, it would be in contravention of the RHPA. And then the PHU would be expected to follow up with the appropriate regulatory college to determine whether there are any actions that would qualify under the HPPA. If the setting falls under the PSS regulation, they could also take action under that. If it is a non-RHP performing a controlled act for the purposes of a cosmetic reason, this would not be in contravention of the RHPA because it only covers healthcare services. So in that scenario, the PHU would consider whether there's any actions taken under the HPPA or the personal services setting regulation.
Okay, thank you.
Happy to ask the next question. So this one, I think is probably best addressed to Dr. Cividino. Kind of a tough question to ask, but in terms of answering, sorry, but I'll tee it up for you. So the question is there any information estimating the risk of transmission or the like rate of transmission or rate of cases that require medical attention? So like beyond kind of redness from microneedling, for example, for any of the techniques or services that you spoke to.
Thanks. So I think it really does depend on the service. There are a lot of case reports. So I mentioned, for example, the written up case of the second-degree burns on the person who had done the yoni steaming, and that was in the Journal of Obstetrics and Gynecology. I think one of the challenges is that people get busy. There are things that come across, but they don't necessarily write them up. What was very clear was the intravenous use of exosomes, and you could see that the sepsis that happened within hours. So there are, but it ends up probably being more case reports than other than the general literature that we'd be looking at in terms of hepatitis B, C, and HIV. And certainly it's one of the things, if we're looking at lapses at Public Health Ontario, then we look at what the activities are that are being done, what reprocessing is being done, and whether or not it's the appropriate reprocessing depending on the invasiveness of the procedure. So that's sort of partly answered the question, but I'm happy if there's any other clarity needed.
Thank you. That's great.
Okay, we've got a lot of great questions in the Q&A box here. So the next question is also for Laura. It's related to Halo head spas. How do you recommend the recommendations of PHO be enforced without a regulatory requirement?
Yeah, that's a great question. Thank you, Ray. So just want to first acknowledge that the whole Medi-spa area is kind of new and novel, and just acknowledge that it's hard for regulations to keep up. While Halo head spas aren't named explicitly in the regulation, there might be parts of the regulation that can be applied if there are issues, for example, with the Halo head spa equipment not being maintained in good repair and sanitary condition. PHO's recommendation on the Halo head spas are, of course, being guided by the best available evidence currently, and their fact sheet that was recently released is able to support local approaches and provide considerations to guide local actions. We would advise health units to continue to follow existing practices for reviewing and implementing the PHO fact sheet as you would for other PHO resources. In terms of what more we can do from the ministry side, we are exploring ways to more clearly identify these links between Legionella and Halo head spas and the risk of the infectious disease transmission. And of course, we will make sure that any future changes are communicated to health units to help your local decision making.
Thank you. I think we've got another question that I think would probably be well kind of addressed by you, Laura. So is there an ability to have individual regulatory colleges defining their scope of practice in different responses as routinely received by the health units?
Yeah, so this is something that we've looked into, and we've spoken to regulatory colleges about this as well. It would be so, in a perfect world we could just have a list of what each RHP is allowed and not allowed to do, and then we could quickly determine the scope of practice and whether that setting would fall in or out of being having the PSS regulation applied to it. But I don't think that's feasible. From what we've been hearing from the regulatory colleges, the scope might not be kind of be able to be dictated that way, to be able to be explicitly listed out that way. So it is an area that we're exploring on how to make this a little bit easier for the health units that are going into these settings and trying to determine what is falling in and out of scope.
Thank you. I feel like we're putting you a bit on the hot seat here, Laura.
That's okay.
So I've got another one, which is, are we required to inspect regulated health professionals that are providing PSS services? Is that within their scope of practice?
So we're not expecting health units to inspect regulated health professionals per se, but if they are going into a PSS setting and they are determining that something that they're seeing is in contravention of the HPPA or the PSS regulation, if it applies, we encourage them to take action as appropriate. Sorry, let me find that question again to make sure I actually answered it. Do you mind reading that out again, Ray? Sorry.
Certainly not a problem.
Yeah.
It's, are we required to inspect regulated health professionals that are providing personal service services? Is that within their scope of practice?
Okay, so I think I covered it, but just to also acknowledge that some of the personal services that they are offering might fall under the scope of their practice. So if it is a nurse practitioner offering Botox, for example, or other injectables, that would be completely appropriate.
With another question. This one looks like it's also best addressed to Dr. Cividino. A longer question, so happy to repeat as needed, but the question is medical head spas, along with other numerous new equipment, new technology, is too novel and hard for regulations to keep up with. So with that come challenges with companies releasing the product with manufacturers' instructions for use that can vary. So the question is, how will we know if the MIFU, those manufacturers' instructions for use, has accurate instructions for the use, cleaning, and maintenance based on the risks that have been identified today?
Yes, that's a really good question, and it's really challenging. And Halo Head Spas, for example, most of those, or many of them, come from offshore. There are no manufacturer's instructions for use that are in them. We know, for example, with a particular vaginal laser, that the recommended MIFU was not consistent with best practice. So it depends on how it's going to get picked up. And I think in that situation and many of the situations that we deal with, it's public health unit, public health inspector that is going in, sees a new piece of equipment, does the right thing in terms of looking at manufacturer's instructions for use. Many of these inspectors are very experienced and more have great IPAC expertise. So recognizing reading through it, so not just good enough to have it, but does it actually make sense? And so we had a back and forth as an example that involved ministry, involved Health Canada, involved the manufacturer, and it's sort of a good news story in the sense that with everyone sort of taking a village, it's a village to sort of make a MIFU a good one, but going back and forth with discussions with these various parties, actually making changes. So if you could look at the, I don't know, 150-page MIFU that really didn't make any sense and wasn't really going to be helpful for preventing infection or even good for the machine itself, it is now a very condensed, slick, straightforward way of offering best practices and clear language. So I think it can be done, but it's a bit of a process. But I would say that anytime there's any question that it doesn't feel right, if you're reading it, doesn't really make sense, then check that out with your IPAC expertise in your public health unit or wherever it is that you're working, for them to say, I agree with you, that doesn't really fit, that's not enough contact time, etc. It's not the right product, and then gradually sort of making changes over time to hopefully get people on the bandwagon here.
Thank you. That's great. There is a quick follow-up question. So if the MIFU doesn't seem right, what recommendations would you have for health units? Do they report it to somebody, or what's the next step for health units in terms of action?
Well, I don't want to speak out of turn, and maybe Lara might want to add to this, but I would suggest that probably speaking with the manufacturer, because they are the ones that have authored the MIFU, and if there are any questions, they would be a good place to start to see if there's any clarity or if you could point out what doesn't seem to be consistent, and I think that would be a good starting point. I don't know, Laura Zaritza, if you wanted to say anything. Zaritza, I know for a fact you've been in touch with the manufacturer, and that's been very helpful.
We did work closely. I believe Toronto Public Health was working as well with the manufacturer, but we've been in touch with the manufacturer in terms of the lack of reprocessing for the device itself. We've gone back and forth with Health Canada as well in terms of the device and the lack of appropriate reprocessing instructions. I can share that we did forward the information also to Public Health Ontario, you guys to do the risk assessment on the device and transmission of infectious diseases as it stands. So we did have a move with the manufacturer. In the end, they've updated their manufacturing instructions significantly and addressed all of the concerns that were identified in Public Health Ontario's risk assessment, which is, it did take a lot of work, a lot of back and forth, but we did have sort of a really great outcome when it comes to that particular device, where we're in a good place to say that they were able to meet all of the IPAC best practices, where we're comfortable for them to use that device.
Okay, thank you so much, Sarisa, for filling in the end of that question, and thank you everyone who is on the webinar for all the great questions for our Q&A session. So now there were a number of questions that we weren't able to get to, so we'll have Sarita provide her presentation, and then we have another Q&A after, and we'll try to answer the questions after that. So I'd like to pass it over to you, Sarita. Thank you.
Thank you, Anne. Thank you all, and welcome and happy National IPAC Week. So over the next 30 minutes or so, we will explore experiences from the field, from public health unit perspective, that illustrate the unique challenges encountered when inspecting Medi-spa type services within personal service settings. This session aims to foster discussions, deepen the understanding, and support consistent approaches to inspection practices in these evolving environments. Next slide. So to set the tone for our discussion, just a little bit of agenda. We will begin by examining the limitations of the existing personal service setting regulation and associated guidelines. Next, we will explore the complexity surrounding the provision of services that are considered controlled acts, such as injectable treatments within PSS. Our third area of focus will be on the use of medical devices and equipment in PSS, highlighting some of the common issues related to their use and reprocessing, including reprocessing and safety. And finally, we will address the use of cosmetic products and prescriptions. Throughout the presentation, we will also share some of the examples from the field just to illustrate these challenges and provide insight into the scope and impact of the issues faced in the field. Next slide. So just very quickly, we will begin by exploring challenges from the field in the application of PSS regulation and relevant guidelines. Next slide. So throughout numerous investigations, we have identified several challenges stemming from the limitations of their current regulation and guidance documents, where they do not adequately address the evolving and growing scope of practice within personal service settings, nor do they account for diverse business models and environments out of which PSS services are delivered. A very particularly complex scenario in applying PSS regulation involves premises with multiple independent operators under one roof. These settings we encounter daily. Typically, the property owner leases individual rooms or chairs to various service providers, with the occupancy of those rooms or chairs often changing daily. As an example, a single room or chair may be rented to different providers on different days of the week. So these rental agreements, they're frequently very informal, and they lack any written documentation or being formalized. And there's also additional complexity that arises when operators share reprocessing facilities, which may be located within service rooms and or serve dual purposes, such as for reprocessing and hand hygiene as well. So just to help you illustrate, just consider walking into an establishment where along a single wall, there are a lineup of self-employed hairdressers where they own chairs, while in a nearby corner, a client may be receiving eyelash extensions from another independent operator, and then another corner, a separate client is undergoing eyebrow treatment. Then in front of you is a hallway leading to multiple small rooms, each no larger than an office cubicle, and each offering a range of personal services. So a single room may be used for facials one day, colonic irrigation the next, and vaginal rejuvenation thereafter. All of these operators utilize a shared reprocessing room that's typically located at the rear of the premise and also contains cleaning supplies, laundry facilities, could also be multipurpose room for staff room, kitchenette, and waste disposal. On the outside of the premise, the operators often use single marquee or name and address to promote their service or their business. And despite operating under a single name and address for promotional purposes, many of these service providers identify as being self-employed and often lack formal business registration numbers. We are observing a growing number of these formalized buildings designed to accommodate multiple service operators who share common areas, including reprocessing facilities. However, the current regulation, the way it is currently written, does not conform to us being able to apply its criteria and enforcement in these unique types of settings that we are seeing. Also, provision of compliance certification is very difficult within these premises, as some operators may meet the standards, while others that are using the same room or chair do not. Next slide. So we're going to continue with legislation and guideline challenges. So one of them is personal service settings without a storefront. We are observing a growing number of personal service operators advertising their services exclusively on social media platforms without an associated storefront and or address associated with their business. Typically, these operators may function in a mobile manner, yet unlike our food truck businesses that we're familiar with, they do not utilize a registered truck or vehicle designated for their business use. So as an example, we did receive a complaint that led us to an individual advertise children's spa party services via social media. The only method of contacting the operators was through direct messaging. Complainant claimed that the operator transported supplies, including reusable equipment and devices, using their personal vehicle with no business registration that was linked to an address or vehicle. Upon inquiry with the operator, they had denied offering any personal services contrary to what was being advertised on social media platforms. This sort of highlights a broader issue and absence of uniform licensing requirements for PSS, including having a business license. So in New York region in particular, 2 out of 9 our municipalities require licensing for personal service operator. We also have challenges with services that are being permitted within PSS. Currently, regulation explicitly prohibits only a limited number of services, for example, the sale and provision of ear candling. However, there has been a significant increase in provision of personal services using devices that have not been authorized by Health Canada, which we'll discuss in the upcoming slide, as well as expanded use of authorized devices such as laser devices. We are encountering various classes of laser systems equipped with multiple attachments, enabling their use for a wide range of services beyond traditional applications such as for laser hair removal. The novel procedures include services such as vaginal rejuvenation and treatments for snoring, while guidelines exist requiring operators, for example, to designate a laser safety officers and ensure applicable laser standards and regulations are met. There remains ambiguity regarding regulatory oversight and enforcement. So it is a little bit unclear who is responsible for monitoring compliance. Additionally, there's also limited guidance available to public health units on what falls within our scope when conducting inspections and determining what is and is not within the scope of regulation and enhance the inspection process. The lack of clarity does place a greater burden on health units, requiring additional time and resources to assess potential health hazard and ensure public safety within these establishments. And another challenge is with the operator training. The regulation states, for example, that every operator of personal service setting is required to take comprehensive health and safety training, which also needs to include some of the relevant practices that can prevent or reduce the risk of disease transmission. However, this training is neither standardized nor consistent across the province. Our field observation consistently reveal a trend where many operators lack fundamental knowledge of the regulation and operational requirements of PSS. Other notable observation is operators' lack of understanding best practices related to infection prevention and control. They often may rely on manufacturers' instructions for use for devices that are oftentimes not authorized for sale in Canada. And in instances where that MIFU is available, they're frequently inadequate, particularly regarding reprocessing protocols. Currently, this training is only required when directed by the medical officer of health or a public health inspector. And in this way, the approach is very reactive and has led to inconsistencies. So to ensure consistency across the province and among the operators, the training should be standardized and mandated by way of regulations similar to food handler certification. Next slide. And then delivery of PSS in medical professional settings. So this is another one of the challenges that we've seen. This is a fairly emerging trend where we're beginning to observe a growing number of PSS providers that are operating out of clinical settings, such as out of medical centers and physicians' offices. So these non-traditional locations for PSS are very challenging to identify for us, as they do not align with the typical profile of PSS establishments. To date, our ability to identify these premises has been very limited, with most discoveries stemming from public complaints rather than proactive surveillance. I will just share a few examples that we've come across. We've had manicure pedicures that are being offered out of a clinical setting. In this instance, the operator entered into verbal agreement with the regulated health professional who owns the medical center. Under their arrangement, the PSS operator rents a room within the facility to offer nail care services. The operator, again, does not have any visible signage at the entrance or within the premises, nor is any form of advertising, digital or physical, promoting their services. The services were primarily communicated through word of mouth and were informally referred to as foot care at the medical center front desk. So this individual has been operating with the medical center for a number of years without meeting any of the regulatory requirements that are applicable to PSS operation. The premise came to our attention only as a result of a public complaint, again, highlighting the difficulty in identifying such non-traditional service locations through routine inspection or surveillance. In another example, we did have injectables that were being offered by unregulated care provider. Unregulated care provider was found offering personal services, and in addition to injectables, from a rented room within an osteopath's office. This operator, again, did not have a storefront presence or any business signage at the locations. Services were promoted and booked exclusively through social media. Following an inspection in the osteopath's office, there was significant noncompliance with the regulation and an order was issued. Subsequently, the operator did relocate their business to a rented room within a physician's office under who was also their medical director. Next slide, please. And this kind of takes us to the chat about delegation of controlled acts. Again, in an effort to expand their services, the PSS operators are increasingly engaging with regulated health professionals, whereby the regulated health professionals are delegating controlled acts to unregulated care providers. These delegated services range anywhere from injectable treatments, such as for neuromodulators, to dermal fillers and fat dissolvers, to other invasive procedures, including vaginal rejuvenation, skin lesion removal, snoring treatments, and colonic irrigation. In the current PSS guide, Q&A for health units lacks clarity on whether unregulated care providers operating under delegation from regulated health professionals fall within the definition of a regulated health professional. And if not, then there's no clear direction as to how UCPs with delegation from unregulated health professionals should be inspected or regulated. Therefore, clarification is required to determine whether UCPs operating under delegation are exempt from PSS regulatory oversight. Another challenge is determining scope of practice for regulated health professionals. Assessing whether a specific service falls within the scope of practice of an RHP is outside of jurisdiction of public health units. The Q&A guidelines recommend consulting the relevant regulatory college for clarification. However, this process is often hindered by the absence of formal communication channels with public health units and regulatory colleges. The onus to identify whether service falls within the scope of practice should rest with the regulatory bodies. And as an example, we had a pediatrician that was providing delegation for injectables and vaginal rejuvenation to several unregulated care providers within the region. When we contacted the relevant regulatory college to confirm whether these services were within the pediatrician's scope of practice, the college advised that it would review and follow up internally if necessary. However, the health unit was not privy to any outcome or decision resulting from this follow-up, further highlighting the lack of transparency and coordination. Also, establishments that are offering controlled acts such as cosmetic injectables and vaginal rejuvenation do frequently identify themselves using terminology such as medical aesthetics, Medi-spas, and medical clinics. Again, a broad definition of Medi-spa was introduced in 2019 PSS guidelines, but has since been revoked. And currently, the term Medi-spa is neither regulated nor defined within existing PSS guidelines or regulation, yet it continues to be widely used. The PSS guideline states that Medi-spa should be inspected to determine whether these personal services are primarily being provided by an RHP. However, there is no established criteria for conducting inspections of such premises, and the term primarily remains undefined. And this lack of clarity creates inconsistencies in enforcement and oversight. We did have discussion with public health units across Ontario, which reveals significant variation in how these establishments are approached. Some public health units report entering Medi-spa premises to assess whether traditional PSS services are being offered, while others refrain from inspecting these locations altogether. So this sort of inconsistency underscores the need for clearer guidance and standardized criteria for identifying and inspecting establishments that fall under this Medi-spa designation. Next slide. Next slide. So just a little bit more on the provision of the controlled acts. Thank you. We are seeing increasing, as I mentioned, number of services being provided by unregulated care providers within personal service settings that were traditionally offered by regulated healthcare providers in a clinical settings. As I mentioned, these services do range from injectables, such as neuromodulators and fillers, to services such as ear syringing, colonic irrigation, and skin lesion removal, such as skin tags, warts, and moles. Again, when determining if the premises falls under the personal service setting regulation and as a result is to be inspected, it is crucial to consider all these different types of services that are being offered, including if services provided fall under the services that are considered controlled act. And it's very challenging for public health units to make these determinations. We do encounter a situation where UCPs perform controlled act services without delegation from a regulated health professionals. And typically these services include skin lesion removal using energy such as electrocoagulation or use of freeze pens and cryopens. We see administration of colonic irrigation and vaginal rejuvenation. So as an example, for colonic irrigation, operators may instruct clients to insert the speculum into the anal cavity themselves to bypass the controlled act. So operators would additionally bypass any assessment, such as performing rectal exam to ensure a healthy anal cavity prior to the procedure, as indicated in the MEFU. Additionally, we have also a number of unregulated care providers that are assessing, diagnosing, and removing skin lesions as part of their services, and using devices such as electrocoagulation devices and freeze pens that are typically utilized to rid the client of unwanted skin tags, moles, and warts and other skin lesions. So in both of these instances, it is challenging for public health units to determine if there is risk, if any, within these premises and whether or not providing such services is within the purview of a PSS and within the scope of an UCP. Again, on a number of these occasions, we had referred such operators to regulatory colleges, and advice given is that unregulated care providers fall outside of scope of regulatory college as they're not their members. We had also escalated these concerns at the provincial level. So at present time, there is no mechanism in place or procedures to help guide health units when they encounter unregulated care providers without delegation who are potentially providing services that are considered controlled acts. So these situations do place PHOs in very challenging positions as public health units are left without clear guidance to address these concerns effectively. And this further creates inconsistencies, again, among the health units in the approach when dealing with such operators. It does also increase the burden on public health units having to navigate these challenges without clear guidance. Next slide. So on the next slide, I will just briefly go over some of the equipment and devices and instrument challenges. Again, there is a number of novel medical devices that are being used for the provision of services in personal service settings. As mentioned earlier, these devices may include devices from those that are non-medical, such as halo hair therapy that Maureen also chatted about, tattoo machines and cartridges, ear piercing devices, to medical devices, such as those used for colonic irrigation, devices used for vaginal rejuvenation, and coagulation devices that are typically used for the removal of various skin lesions and growths. And also devices that are being used for facial treatments, such as plasma pens and hydrofacial machines. So again, depending on the type of the device, some devices may be authorized for sale through Health Canada, who do evaluate medical devices for safety, efficacy, and quality. There is, however, a very large number of devices used in personal service settings that are not authorized for sale. Therefore, they have not been assessed by Health Canada for safety, efficacy, and quality. As a result, this could pose a potential risk to health to clients. The PSS regulation does not prohibit premises from using devices that are not Health Canada approved, again, placing burden on health units to navigate challenges that come from use of these devices, such as determining reprocessing requirements for MIFUs are inadequate. Next slide. So in order to assess the devices and their use for services that are being provided, our staff would review the manufacturer's instructions for use of these devices. In review of the manufacturer's instructions for use of the many devices, a number of concerns we've identified. One of them being qualifications of the user of the device. So oftentimes MIFU may specify the use of the device explicitly, such as devices to be used by a licensed healthcare professional, by prescription only or physician use only, while other MIFUs may have a little bit of a softer language, indicate that the device is to be used by trained professional or qualified professional. Some devices go as far as to indicate that certain levels of energy can be applied by providers such as estheticians, while some of the higher levels of energy application are intended for licensed healthcare professionals. Again, interpreting this terminology, such as licensed professionals, is challenging and is unclear as to who the qualified user of these devices is in Ontario. So who should be using these devices? There is also lack of guidance and action, if any, that PHUs need to take where devices meant for licensed healthcare professional use only are being used by unregulated care providers without delegation from an RHP. There's also lack of clarification as to whether devices explicitly intended to be used by a physician and or healthcare professional, if used by UCP, would require that delegation. MIFUs also may indicate in which instances devices is to be used. So currently in Canada, medical devices that are authorized for sale for colonic irrigation, all of them state that such devices are to be used for colonic irrigation prior to medical procedures such as before colonoscopy. However, we see these devices being used a lot off-label for colonic irrigation for holistic purposes. Again, at the provincial level, it was suggested that the off-label use of medical devices by an operator can be taken into consideration when assessing whether or not the service constitutes a health hazard. However, assessing off-label use as a health hazard is very challenging without clear process or tools to do so. So as an example, removal of skin tags, warts, moles, and other skin lesions are conducted using various devices, as I mentioned. While skin tags, for example, may be benign and not below the dermis, the diagnosis of such skin lesion may potentially be a controlled act. Again, at the provincial level, we are advised that a PSS operator should only be removing skin lesions that have already been assessed by a qualified healthcare practitioner as being benign. The challenge with this is for public health units, the process by which the inspectors would assess whether or not the skin lesion growths were previously assessed and diagnosed by regulated regulated healthcare provider, and which skin lesions may potentially be rooted to below the dermis and therefore potentially fall under the Controlled Act regulation. And finally, some of the MFUs oftentimes specify in which settings devices may be used within. So some of the examples of setting indicated by MFU could include, but are not limited to, for example, devices should be used in a professional setting or in a surgical setting or a physician office setting. So defining these settings in Ontario is challenging, and as such, guidance and processes are needed for when these devices are used outside of clinical setting in an area such as personal service settings. Next slide. So when we are conducting an assessment, whether a device is being adequately reprocessed, our staff again reference the manufacturer's instruction for use to establish the processes that are required by the manufacturer for reprocessing of their devices between client use. In review of the MFUs, we're often finding that they are inadequate or may not conform to best practices in IPAC in Ontario. As an example, we have recently come across a hybrid fractional vaginal laser device. So this is a device that we spoke, Maureen spoke in her slides and during Q&A. This device is approved by Health Canada, but is widely being used off-label for vaginal rejuvenation in a Medi-spa type of setting. Again, we had requested at the provincial level establishment of required level of reprocessing of the device, and it was concluded that MFU does not meet infection prevention control best practices for reprocessing. One note was that the plume of the smoke from the laser in this device is at risk of being contaminated with HPV, with the possibility of the laser handpiece also becoming contaminated during procedures. And if proper clean disinfection is not done, that could be transmitted to other clients, from client to client. We also came across devices that have lack of or inadequate instructions for cleaning and disinfection. Again, as an example, we shared this before, was a halo recirculating head spa. This device is not a medical device, therefore not found on MDAL on Health Canada's directory. And again, we did make a request at a provincial level to establish the required level of reprocessing of this device. Again, whether a device is approved for sale or not, once it is established, the device is MFU do not conform to the best practice in IPAC in Ontario and in Canada. There's a little bit of lack of clarity and guidance to escalate these concerns beyond level of individual health unit. Next slide. So just finally, chat a little bit about cosmetics and prescription medication. We have entered multiple premises where we had come across prescription medication used by unregulated care providers for services to clients. Again, these type of issues we often come across during complaint inspection where clients had reactions following services. We have also been involved in investigations that were initiated by way of complaint from Health Canada. In an example, we had received a complaint where a client experienced severe reaction following injectable service. During the inspection of the premise, we've encountered a number of injectables that were in other languages and without that drug identification number. In several other establishments, we have also come across prescription medications that are licensed, that may be licensed in Canada, but were prescribed to the operator as opposed to for clinic use. So challenges we often have in these circumstances is having established processes that public health units are to utilize in the management of these products. In York Region, our public health unit refers such products to Health Canada, and or depending in situations, we may refer to the College of Pharmacists. These products may be put on hold or seized from the premises if they are concerned that product would continue to be used by the operator. But again, just wanted to reiterate that expectations of the public health units are not well defined when it comes to these types of products. Next slide. We do also come across a variety of cosmetic products that are used on clients. And again, for example, these products may be used along with microneedling and other facial services. Some injectables may require compounding, such as hyaluronidase, which is a lip filler, a dissolver. During one of our investigations, we did find out that the compounding pharmacy was being investigated by Health Canada, and the product may not be in compliance with the federal legislations. Again, we were only made aware of these findings by way of a complaint and an investigation. And it becomes very challenging for public health units to deal with these circumstances without having those established processes the public health units should utilize in the management of these products. So next slide. This does bring us to the end of our presentation. And I hope that highlighting challenges we experience in the field sets some groundwork for meaningful discussions and some collaborative efforts to improve our practice. Again, thank you so much for your attention.
Thank you so much, Saritza, for that terrific presentation. Much appreciated. Now we'll move on to our second Q&A session. So if Dave, Ray, and Catherine could join us again, that would be awesome. And we will answer questions live from the audience. If you have any questions that you really want to ask, please remember to put them into the Q&A, and let's get started.
Thanks, Anne. Zaritza, I'm going to direct the first question to you. There's a couple about education. We'll combine them. So in the PSS regulation, health units and public health inspectors can provide direction for operators of personal service settings to obtain further training on the specific services that they offer. What are some examples of training resources that can be directed or promoted? And then similarly, is there a list of recommended health and safety information available aside from the PSS courses that are offered by a couple of the health units?
So that's why the reason we did highlight the lack of that standardized training across the province so that we can direct our PSS operators to have that uniform and standardized training. I know some health units do have some form of, I think, training on sterilization, or there's also training on the, for example, on Public Health Ontario guide, a lot of different infection prevention controls. So typically, depending again on the situation, those were some of the resources where we direct our PSS operators. But one of the things that we do wanted to highlight through our presentation is the lack of that standardized training for PSS operators and having the education. And in terms of, you know, we redirect them back to regulations so they're familiar with the regulations that they have to follow and maintain. So there's a lot of education one-to-one. So our public health inspectors do spend a lot of time in conversing with the operators.
Thanks.
Okay, so the next question is for Laura. Excuse me. Are public health units required to conduct a risk assessment of every premises where controlled acts are performed every year? In practice, it seems that beauty premise introduced new services without notifying a health unit, and as a result, some services that would fall under the PSS regulation fall under the radar.
Yeah, that's a good question. So it does seem very, very work intensive for a health unit, but under our PSS regulation, we do have a section that requires every person who intends to operate a personal service setting must provide notice to the public health unit, to the medical officer of health, when they do add certain services. They have to provide that writing ahead of adding these services. There might also be in certain municipalities local business requirements that have that require you to be in contact with the health unit to renew your license. So I know that's in our regulation. I'm not sure how often it happens in practice.
Thank you. The next question is also for you, and then maybe Zaritza might want to put a little bit of input on it as well. Where a regulated health professional, i.e. an RPN, is providing foot care, but also offers other services such as tattooing, would they be inspected as a PSS, specifically the foot care portion?
Yeah, so this is kind of one of those areas that we're trying to discuss quite a bit internally, and I think I touched on it slightly before. It would be nice if each college could have, you know, a list of what's in and out of scope for each RHP, but often it doesn't work like that in practice. So right now the recommendation is to kind of reach out to the college if the health unit has any concerns about the services that the RHP is providing. One day, hopefully, we'll have more of a streamlined process or be able to give more of an answer once we collaborate with the colleges a little bit more and try to determine how best to go around this question about scope of practice. I know it's quite challenging. And Zaritza, if you have any advice or any personal experience about how your health unit goes about this, feel free.
Well, I think this is more like a ministry question because I think these are some of the challenges that we experience in our health unit as well, but that we redirect typically to the ministry and the colleges.
Thank you.
And I'm happy to jump in with another question. So, Dr. Cividino, this one will be addressed to you, and it's regarding Halo Head Spas again. So, the question is, if the fixture is plumbed and it's a permanent fixture, what's the rationale for having a MIFU or a manufacturer's instructions for use? Wouldn't it just operate like a regular hair wash sink? I don't know if you have thoughts or comments to that.
Sure. Well, I think it depends on exactly what the product is. So I agree that if there are all of those things that are set up for a hair salon, for example. So if it's following that and there isn't anything different about it, then that's reasonable. It's the recirculating piece that's really the concern. And also if there is something then that would need to be cleaned and disinfected in between. So I think it's really having a very clear idea about what is being used. One thing I can say is, as part of an investigation into the Halo Head Spas, not only were these devices being used routinely, like a number of them lined up, but as well, they had sort of homemade or sort of Frankenstein their own sort of way of making Halo Head Spas attaching to sinks and things. So it has to be something that would be considered to be approved and from on the building and maintenance side of things. Like there are a number of things that would come into play. So I think that it's really knowing what it is that you're dealing with to really be able to answer that question clearly.
Thank you. I have another one for you, Dr. Cividino, and this one is in terms of exosomes. So, wondering if you have any thoughts or comments on is there a difference between synthetic origin and human origin exosomes in terms of approval? From the author's understanding in the presentation, no exosomes are approved for use in Canada.
That's my understanding, Dave, at this time. So I know that the human-derived exosomes is the area that's currently under review by Health Canada, and it's very timely in terms of the discussion because they're looking, I think, by the end of the month to have had input back. And I know Public Health Ontario is providing a response, and they've gone very widely to get information to return. Looking at it from a risk perspective, I think that's a very good place for them to start. As I also mentioned, in terms of the animal exosomes, there could be risks in terms of zoonoses, Q fever as being an example. And there may be additional risks, not necessarily IPAC, but other risks depending on what the synthetic exosomes would be. So there is no exosome approved by Health Canada at this time that I'm aware of.
Thank you.
Okay, so we continue to have a lot of questions, although we are kind of continuing to go through them. So I think the next one here could also be sent to Laura, and I apologize for continuing to keep you on the hot spot here. So if a regulated health professional is a business owner but does not provide services, are they to be inspected?
So currently our regulation refers to the services being provided and doesn't touch on, and sorry, when I say our regulation, I mean the PSS regulation. It doesn't touch on the owner and operator. It only specifies the services being provided in the setting. So it doesn't matter really, I guess, the owning and operating portion of it. It would be mostly the services provided.
I have a question here, maybe, Zaritza, I can ask you. When public health units are addressing complaints and encounter unregulated care providers without delegation, how can you determine whether they are a licensed regulated health professional? In the previous presentation, it was mentioned that PHUs aren't able to verify the licenses. So is there a way that PHUs can address this?
I can just say from our perspective, we do ask if whether or not they have a delegator and who that delegator is. So we do by way of it's just verbal verification that we do at York Region. So we ask them to state who their medical director is, could be a nurse practitioner or a physician, and for their license, so we get their verbal attestation.
Thanks.
So Dave, Ray, and Catherine, do we have any more questions for our panelists? If we don't, I have a couple of questions I would like to ask. So for our panelists, thinking about your presentations, and if you could, we'll go one at a time. Can you tell us what your take home, the one nugget that you would like people to take home from your presentation today? So let's start with Laura, as you were the first presenter. What is the one thing that you would really like people to take home from your presentation today?
Sure. Thank you, Anne. So I guess our take-home message would be that the ministry is very much working on developing any kind of strategies, resources, anything to help with health units work in this area of Medi-spas. It's kind of an up and coming area. We had a pandemic interrupt a lot of our work and a lot of our momentum. And we want to make sure that the roles and responsibilities are very clear because we're very much aware of health units filling the gaps in these legislative areas that don't have any enforcement right now. So we want to make sure that we're building this in a sustainable way. And yes, very much committed to hearing feedback and hearing your perspectives and being able to build good policies based on that.
Thank you, Laura. So Dr. Cipadino, same question for you. What is your one nugget of information you want people to take home from today?
Keep the conversation going. I think that we are in somewhat unprecedented times with what's happening with the burgeoning industry in terms of personal service settings, where there's sort of a blurring and a blending and a crossover in terms of regulated health professionals, as was stated, in sort of hiding in plain sight, where you'll have these little mini PSSs inside a doctor's office, for example, and they're sort of falling off the radar. So the other is there are always new things coming up. So I think it's keeping eyes wide open, feeling really free to contact the local public health unit. And certainly Public Health Ontario is very keen also, because it's usually through the eyes and ears of the public health units that we actually then get introduced to these issues. And then we have, wonderful resources and supports through library and others for us to do further investigation. And then that's how you build a repository of scientific information that you can then make some changes. So it's I think to look at it as very much a process, but to keep eyes wide open and enjoy the ride.
Okay, thank you, Dr. Cividino. Yes, so keeping your eyes open and always looking for that new thing that's just coming on the horizon. Okay, so Zaritza, same question for you. What is that nugget for taking home from your presentation today?
I agree with both Lara and Dr. Cividino, and I guess even for me, it's just a growing need for public health engagement, and again, engagement with the evolving those other healthcare adjacent environments as well, with regulatory bodies. And it just reinforces the value of collaboration between public health, again, even with our operators and the provincial and even federal colleagues, to hopefully get to work towards common goals and hopefully sort out some of deal with some of these challenges that we're seeing in the front lines.
Wonderful. Thank you, Zaritza. Okay. Well, there are no more questions in the Q&A pod, so I guess we will wrap it up for today. So I would like to really thank Lara, Dr. Savadino, and Zaritza for their wonderful presentations. I'd also like to thank our panelists, David Riding, Ray Gullickson, and Catherine Kerr, for manning the Q&A pod. You guys did an excellent job. And I would like to thank everyone who joined us today for this event and wish you all a happy IPAC week. You can expect to receive a brief and anonymous survey for today's session, so please try to complete this to help us improve our programming. Thank you so much, everybody. Bye-bye.